Hello, thank you so much for joining us today. I am Tina Brown with Dental Practice Enhancement, and we have a special guest with us here today, Theresa Sheppard. Our company, Dental Practice Enhancement, is an enhanced billing company. Not only do we submit claims, post payments, we send statements, keep track of outstanding claims, and we do things like verification, complete breakdowns. But this morning, we do have a very special guest with us, Theresa Sheppard. Theresa is a registered dental assistant, speaker, and author with experience in all clinical and management aspects of the dental office. This, coupled with her extensive hands-on frontlines experience of over 35 years, including over 25 years as an office manager, uniquely qualifies her to train dental teams. She speaks on risk management, HIPAA, insurance billing, and mouth-body connection. Theresa's passion for dentistry and love of teaching merged when she became the owner and director of Career Express Dental Assisting School, as well as a provider for the California Radiation Safety Course and Dental Board of California's Continuing Education. She provides clinical and administrative skill enhancement and training. Theresa is a member of many professional organizations. Please welcome Theresa Sheppard.
Good morning. Thank you so much for having me. I really appreciate seeing all of you this morning. And if you just give me 1 second here, we'll get going. I do have a couple of housekeeping chores that I need to take care of today. We are recording, but this is also considered live units for those of you that want a unit. So what you need to do with that is when you have to participate because it is considered live. So what I'll do is I will be posting questions throughout this hour. And if you can just please answer those in the comment or the dialogue box, that way we know that you're active on the call and we can get information to you. Now, other people are not going to necessarily be able to see your answers, so don't be shy. You'll receive a CE certificate by email within the next couple of days. Secondly, I am a teacher by nature, so I love to engage with my audience and I love to have questions and answers. Today, though, we're really limited on time, and while I still welcome questions, if you can hold them to the end, I would appreciate it. We're covering a lot of information, so I may answer your question in another segment. And we will take the last few minutes and Tina will be joining us and we can answer any remaining questions or listen to comments that you might have. So this is for general information only. I'm not an attorney, so any specific questions should be addressed to your liability provider. So my goal today is to discuss how we can better serve our patient and mitigate our risks. And since insurance and fraud go together, we'll be talking a lot about both of those things. I have been in dentistry longer than I care to admit, and I can tell you there are many points of confusion and misinformation about dental insurance, really as there are stars in the sky. You may be surprised to learn that the biggest piece of misinformation is that the patient actually has insurance. That could not be further from the truth. You have car insurance, and you have homeowners insurance, and you have medical insurance, but you don't have dental insurance. This is at best a dental benefit plan that helps with copays. But even your homeowner's insurance doesn't fix your broken hot water heater or buy you a new fridge, right? So insurance doesn't cover everything. Many times the offices fall short on documentation and diagnostics just because basically they run out of time. This not only puts the hygienist and the doctor's license at risk, but how long do you think your paycheck is going to keep coming in if your doctor can't work? So the biggest piece of risk management pie is fraud and supervised neglect. Insurances don't dictate treatment. The diagnostics, the treatment plan, the protocol, the procedures are the same regardless of who's paying the bill. So I want to stress that we need to get out of the mindset of insurance, but that's the reality that we pretty much all live in if we're in private practice. So let's talk a little bit about what we can do to mitigate some of our risk. So healthcare fraud is a federal offense and can carry a federal prison term of up to 10 years, in addition to significant financial penalties. And the one thing that I really want to stress, and I think it's not widely known, is auxiliaries are not exempt from being prosecuted. So if you are doing services that you're not licensed to do, or you're doing services without the diagnosis and treatment plan from the doctor, then you are putting yourself at risk. And so we want to make sure that you don't do that. Yeah. So here, I'm just going to briefly go over the various things that we see in a practice every day. We're just going to briefly review it. So vicarious liability is where, even though a mistake was done by the team member, the doctor is still responsible. And some of these things, like the vicarious liability and negligence, can almost fall into the same category. Now, one example of that would be, let's say a patient needs pre-med and they come in for their appointment and they forgot to take it. Well, we don't want to reschedule them, so we usually keep a stock of amoxicillin or Keflex, handy just in case. So the assistant says, oh, you didn't take your pre-med, let me give it to you. So she brings you some amoxicillin and you swallow those and realize, oh, you have an allergy to penicillin family. That was a huge mistake. Patient's now into anaphylactic shock and on their way to the emergency room, all because we just didn't review the health history. Another issue is supervised neglect. What that means is we are continuing to provide services for these patients that are well below the standard of care. And the biggest area of that is in the perio realm. We're profiing perio patients. We really need to be careful about that. That's a problem. Financial and administrative fraud, some of the things that might happen there, and we think we're helping our patients. We think we're helping them because, they have out-of-pocket costs and we want to help them not have those. We feel that maybe their benefits should be covering something else, so we want to make sure that we give them a benefit for it. But we're not helping our patients. We're really hurting our patients, and we're definitely putting our practice at risk. So sometimes we have to manipulate a calendar date, or we think we have to. Let's say it's December 23rd and you just broke a tooth and you're already maxed. Why are we prepping that tooth today? Could we not do a provisional and then reschedule in January versus prepping it out today and billing it out in January? Now, I understand there are some companies that do pay on delivery, and that's all part of what our breakdown needs to be clear on. So we know how to treatment plan and treat these patients. But we want to be very cautious of, you never want to change a date. Do you collect the patient's full copays? A lot of offices write off copays because they think it's a great marketing thing. Hey, you can come in here and I'll only take what your insurance covers. Well, do you realize that if you give the insurance company a discount, that you have to give your patients a discount? That if you give your patients a discount, you have to give your insurance company a discount as well, because that is not your full fee, and that is what you're billing the insurance company for. So that gets really tricky, and that usually startles most people. Are you submitting claims for services when non-covered services are provided? Such as you're really doing a perio maintenance, but you're billing for a pro fee because they have a benefit for that. And failing to obtain photo ID on a new patient. I teach HIPAA as well, and this is a big HIPAA issue, but it's also a fraud issue. A lot of patients now are using other people's information, particularly if you are in a Medicaid office. That seems to be a real issue with people coming in just with the card, but they're not getting IDs. So we want to make sure that we are verifying. So again, we talked about discounts. Who is eligible, and can I give a discount? You certainly can give discounts. There are very specific ways to do that, and I'm not going to go into that here. but you certainly can. Just be very cautious on how that is implemented. Coding makes a difference. Everything that we do is about coding, and whether or not we bill a company or not, it's still about codes, because we're talking about procedures and we're talking about what did we do today. And regardless of the payment source, you cannot change the codes. You always, always, always bill for what you actually do. I can't stress that enough. It doesn't matter if it's a benefit or not. It doesn't matter who's paying the bill. Code for what you do. Also, we need to keep in mind that a benefit plan or an insurance company, they can change those codes. They reassign the codes many times for processing, to make either something a benefit or to give a patient an alternate benefit perhaps. But you'll see that on the EOB from time to time. Now keep in mind, they're not dictating treatment, although we like to think they are. They're just making this procedure code fit within the patient's benefit plan. So I'm going to ask my first question, and if everybody could please respond that would like to participate today. So my question is, what are some of the most common codes that you see reassigned on EOBs? So I'll let you guys work on that, and I'll just keep talking. Financial concerns or misunderstandings are going to cause ill will, bad publicity, and the loss of a patient faster than anything else. You have to have financial policies in place, solid financial policies. We are the only industry, I believe, that people think that they don't have to pay. You would never go to get your car repaired or go to a grocery store or a restaurant and then want to know if you can bill me. I don't understand why it's still a problem with dentistry, except that we tolerate it and we allow it. That's why it continues to perpetuate. We are not the bank. There are many awesome financial institutions, Care Credit being really the primary one that we are all familiar with. But whatever financing company that you choose, please just do not be the bank yourself. There's liabilities and risks in that as well. So what we want to do is we want to really eradicate any of those problems before they start. And we want to make sure that we have thorough treatment presentations and understand their benefits. And we want to use wordage like this. Your dental plan does not cover your needed service. Your employer has chosen to omit this procedure from your benefits. Our friend Lois Banta gave us those phrases a few years ago. I heard her say that, and I've loved them ever since because they are absolutely true. In an insurance-driven practice, though, most patients are less concerned with what treatment they're getting, and they're more concerned about fees. So we want to make sure that we do use the appropriate wordage and turn those negatives off you, because they will blame you for their benefits, and back onto the employer, really where they belong. All the patients want to hear is a fee for the service. They don't care about anything else. So we want to be very crisp and very clear. And all of our services should be delivered in such a manner that enhances value. But I also find that a properly delivered case presentation is the golden opportunity that a practice has for educating the patient and gaining their trust and compliance. Trying to explain a multi-procedure case when the patient's lying on their back and they're feeling kind of trapped is not the best setup for success. This is another reason that an absolute thorough breakdown, complete with a history, is crucial, and your coverage tables in your software are accurate. Otherwise, all you're going to be doing is guessing when it comes to copays and benefits, and that's where we're going to get into trouble. Even though that this procedure, as far as breakdowns, is an absolute must, it can be time consuming when we're constantly interrupted by the phone or with patients that are presenting at the time, and that is our priority. So this is a perfect example of one area where a virtual assistant can bring value to a practice. Some issues that I see in billing are stay plates versus resin partials. let's say, for example, a stay plate is done on a patient. Sometimes I see resin partials being billed out, but really what the patient's being delivered is a stay plate. I also see stay plates being billed out for posterior teeth, and we want to be very careful about that because the language in the CDT codes is that stay plates, or interim partials, as they're known, are for anterior teeth only during a period of time for healing. They're not meant to be extensive appliances, so we want to be very careful about that. What kind of exam are we doing today, if at all? If a patient calls for a toothache, are we doing a limited evaluation, an office visit, an emergency palliative? When I go in offices or I do chart audits, I see all the time limited exam, limited exam, limited exam, when maybe we could take a look and have a better benefit for our patient by really examining what it is that they're coming in for today. So it's super important that we know. We have to know frequencies. Many office visits are going to be counted as an exam, and then you've got an upset patient because that visit was denied for frequency. Another reason that we need thorough breakdowns. Triage is an issue that there's a lot of problems with, and I see all the time patients calling at the last minute, Friday afternoon, practically in tears because they're hurting so badly, and we squeeze them in. Now, typically this is a non-compliant patient to begin with, and what we find is they get into that practice and then they say, oh, it's been hurting for 3 or 4 weeks. Come to find out that, well, we tried to refer you to the endodontist a year ago, but you didn't go. So there's a lot of things with that. Now, we could have really saved time to the practice. We could have saved time for the patient. We could have better worked this into our already busy schedule if we just took some time to get some information and then we prepared that properly. Is this really an emergency? We really have to know that because this is a time drain. Emergencies, everybody knows that, is a time drain on a practice. And we have to see emergencies, but we have to see legitimate emergencies. So please take time to do a thorough triage. Another area I see are sealants versus posterior composites being billed incorrectly. If you've got incipient caries and what you're really doing is more of a sealant type procedure or an infiltration, I see it billed out as a one surface composite all the time. So we want to be careful. I see lots of practices that this would be a prophy patient and then we would reevaluate and have them back for root planing. This is not a prophy patient. I'm not here to determine clinical need for anybody, and I'm certainly not going to diagnose anything. That's up to the doctor, but we have to be aware of what our pitfalls are, and this is a huge one. For our hygienists out there, please, please take advantage of some of the new codes that are being utilized now. Scaling in the presence of gingival inflammation is an awesome code. It's been here for almost 2 years. Please use it. It's a great stepping stone. But we really need to get our perio protocol in place. Training. We have to have training. Experience is not expertise. Please do not fall into the trap of, well, I've been billing insurance for 15 years, therefore I'm an expert, or I've been office manager for this amount of time or that amount of time. And I understand that because I sat in all those chairs. But there's a big difference between experience, which just means time, and expertise, which is more technique sensitive. You can become an expert in a very short period of time with the proper training, but you may never get the proper training. So we want to make sure that all of our procedures and policies are in place, that we have written protocol, and that we have just all our ducks in a row. I can't stress that enough when it comes to risk management. We want to make sure we have a dedicated person and a backup person in charge of following up on pre-auths. If your office sends pre-auths, we need to make sure that the people that are receiving those and then contacting the patient really understands what those pre-auths are saying. Some of them are very confusing. And if the reason I say backup is because we all need to be somewhat cross-trained, I believe. I like that theory. And another reason is because if somebody's on vacation or they're out ill, nothing should stop. The business should not stop because one person is not there. When I do chart audits, this is absolutely the biggest problem that I see is no one is double checking that the coding that's entered on the final claim is correct. So what I mean by that is the documentation is not matching what's on the ledger, is not matching what got sent to the insurance company. So I know we all want to close out our day immediately and be done by 5 o'clock, but that's not always maybe the best course if we think about in terms of verifiable information and using the right codes, because this is an area where we get miscoded. Does the lab slip match the final services performed? I see this all the time as well. Maybe the lab slip says something completely different than the documentation, and the documentation says something completely different than the treatment plan. So we have to have consistency. Consent forms have to be signed after the patient's consultation. And don't forget to make changes if the treatment plan alters. That's another issue that I see a lot is if an assistant is in the back and let's say we're prepping treatment plan for a full gold crown on 30, ended up prepping for a all ceramic instead. And if the procedures are set complete from the operatory, that may or may not get changed. And then what happens is the services that we build out are really not the services that we performed. That a moment, and let's ask our second question. For my admin team, do you have written protocols? How were you trained in order to do your job? Who trains you? One thing I want to bring up here, and the reason that I have this in red is because get consent for all treatment, including refusal of treatment. Now, there's a lot of misconceptions about what a refusal is. A refusal does not mean the patient can sign not to have certain procedures and have a lesser procedure. Please do not ever have your patient sign away. Let's say that they need 4 quads of root planing and they've signed a release saying, I'm not going to hold you responsible, just do a prophy. That cannot happen because, first of all, the patients can't dictate treatment. Second of all, you cannot have a patient sign anything agreeing to receive substandard care or care that is below the standard of care. So we want to be very careful in that. That's a huge trap that we all fall into. Now, there's another reason for that is, let's just say, for example, a patient is maxed and they break a tooth. They don't want to have that crown done today. Okay, I understand that. That's still a refusal. You're still being told that this needs to be done. But what is the reason? The reason is I just need to wait 3 months. I'm not completely refusing it. And that's okay. We can do a provisional and we can get you out of pain and we can manage the situation until you're in a better position to do that. You cannot have a patient refuse x-rays on an ongoing basis because how are you diagnosing? One thing I do want to say too is you cannot force a patient to do any treatment. You can certainly, they can refuse anything that you suggest. They have the right to do that. But please do not fall into the trap of doing something lesser. You also have the right not to treat them. This is a situation that I saw in one of the offices that I went into, and it was really a sad situation. This lady had lower anterior 22 to 27 crowns prepped, and this was in February. So in June, she called the office very upset because her provisionals had all fallen off and her tissue was in terrible shape, and she had a broken tooth, and she was in a lot of pain. So she calls the office and says, you know, my temporaries are off. So they said, come on in. They were supposed to call her when the crowns came back. Nobody ever did. Now, her teeth are non-restorable. The doctor and the assistant kind of chided her a little bit and said, you should have called me when these first came off. And the patient shot right back with, you were supposed to call me. Nobody ever did. Well, this patient, like I said, non-restorable, she goes to the oral surgeon. Guess who pays for the extractions and the implant-supported bridge? The general dentist. Why? Because you cannot defend that. No one called. They said they did, but nothing was documented. There were no written or verbal post-op instructions. And I can't stress enough, make sure that you document that. There was nothing clinically wrong with the preps. They were probably beautiful, but that doesn't matter. It's all about the details. So when I do half-day or full-day workshops on this, we do a little game called What's Wrong with This Chart? And I always encourage people to bring their own documentation, redacted of course, but these are charts that I've actually personally had experience with, and I haven't changed a word. So 8 years since last prophy, moderate calculus lower anteriors, moderate to heavy tobacco stain, mild to moderate bone loss, especially upper right. Patient only wants a light cleaning. For my hygienist friends, I'm not sure what that is. Maybe you could enlighten me. Due to gum tenderness. So we used hand scalers to remove some of the calculus. Polished and flossed, told the patient they had a lot of bleeding, so should come back for a prophy 2. She takes metformin for diabetes, but doesn't have time to stay today for x-rays and exam, and is going to call back to reschedule. All right, what's wrong with this chart? I can see quite a few things. First of all, why is the hygienist seeing the patient when the doctor hasn't? And hemo is infection. Infection is not a prophy. And again, I'm not dictating treatment. I'm just going off what is the standard of care and the issues that we see all the time that get patients and practices into trouble. New patient exam. Updated patient's health history, no changes. Patient has toothache lower right for 2 weeks, taking penicillin, took PA. Use lidocaine to anesthetize number 20. Carries into pulp, place crown buildup until can reschedule because we don't have time for root canal today. 18 head deep caries, placed IRM, scale and polish, electrosurge, next visit. It's been a long time since I've been in dental school, but the last I looked, the lower right was not number 20. So where's the error in that? Is the x-ray the wrong tooth, or did we chart the wrong tooth? There's so many other things wrong with that. I don't even want to go into it. An example narrative, this is how more online of how a narrative should look. Health history review. Patient states takes metformin, uncontrolled blood sugar. There's your first clue right there, uncontrolled blood sugar. Allergies, blood pressures. Are we taking blood pressures on everyone? We need to be. What kind of anesthetic did we use and how did we use it? And then we've got the procedure. We root planed. We've got documentation. We've got bone loss. We've got calculus. We've got hemo. We've got, we irrigated. We also have a reiteration of reviewing the treatment plan because number 2 had deep decay on the distal. What did we dispense? And you notice down here, written and verbal post-op instructions given. It doesn't need to be any more complicated than that, but it has to be there. Please, please, please. Written post-op instructions are so important. And then we know right away, what are we doing next visit? we not only have our next visit, we have our projected visits put on here, because anybody should be able to look at this chart and know exactly what we did and exactly what is coming next. And trust me, an attorney will do that. So if you didn't see it, you didn't say it, you didn't do it, it didn't need to be done, and it doesn't exist. That's the mantra. And I can give you everything that you need to know about your documentation in 2 words, and those 2 words are prove it. Take a look and think back at those samples of documentation that I gave you. If you do go into a court, your documentation is going to be put up on the Jumbotron for everyone to see. Would it pass the test? Being sued is not about bad dentistry necessarily. Typically, it comes from lack of training, lack of coding properly, lack of documentation, lack of follow-through, lack of good financial policies. It has more to do with all of those things and less to do with actual clinical dentistry. But that doesn't matter. What matters is, are you defensible or not? Anybody can get sued at any time. I can sue you today because I don't like the color of the shirt that you're wearing. But where does it go from there? And if you are not prepared and you've got all kinds of coding issues, particularly because that is insurance fraud, you've got lack of documentation, you've got lack of diagnostic information, you didn't probe, you don't have the photos, those are all things that make you indefensible. So much to do. I often see a new patient come and go in about an hour and a half. That includes x-rays, spot probe, and sometimes root cleanings. Patient wasn't given a proper explanation of their disease. They didn't understand the treatment. They didn't sign a consent form. They didn't see the dentist until the visit was almost over, and was understandably very upset when they were asked for a large copay on their way out. They were told they just needed to have a deep cleaning. Well, what did the patient hear? Cleaning. I get free cleanings. Please, if you can eliminate 2 words out of your vocabulary forever and ever, it would be deep cleaning. Patients don't hear anything but cleaning. And cleanings are preventive services. They're not therapeutic. So we need to make sure that our patients understand that. So many offices put a new patient on the schedule with hygienist first. That's really typically not a good idea, because the doctor needs to see the patient first. And what if the patient needs root planings and has this copay? Are they not prepared to pay that today? By the time everything gets done, are you in a position to be able to provide those services? Okay, those of you that know me know I'm really super particular about diagnostics and x-rays in particular, since I teach that. And you would be still surprised to know how many offices do not use their intraoral camera. Your intraoral camera is the most valuable piece of equipment that your office possesses, other than your sterilizer, because pictures don't lie. For example, this little occlusal amalgam we've got here on the lower right, perhaps that looks pretty undermined, and perhaps there's some fractures on there. You might be able to probe that fracture. That cusp might pop right off as soon as you start to get that old amalgam out of there. But there's a little tiny silver spot on an x-ray that just shows there's a little tiny existing amalgam on that tooth. Companies aren't going to want to pay for a crown or an onlay on that. But if you've got the photo, you can do that. We get into also a habit of taking bite wings, and we never check on existing root canals. We never check on other problems that we have in other areas. You look at what we miss. We can see cysts that might not have been available. We can see bone loss. So we want to make sure that everything is viewed at some point in time. Doctor has to be the one that prescribes x-rays. We don't have the patient just on a standard once a year bite weighing, every other time anterior PAs. These are all samples of x-rays that should have never been put on the view box for the doctor. These are non-diagnostic x-rays. They're overlapped, they're elongated, they're foreshortened. Please don't let your doctor diagnose off of these. Even though that we are not technically, quote unquote, licensed to diagnose, we all know what a diagnostic x-ray looks like. So please do not do that. I have to stress that. This is another patient that I had witnessed to where the doctor was given this and it was fine. He actually said, no caries. Well, we took another film and look at what was more accurate. There's a lot going on with this patient. So films have to be accurate. For you that don't know Jen's vision, go on Facebook and look her up. This happened because a patient was not given goggles. So even though that's not part of fraud, it is part of risk. And risk mitigation covers a lot of areas in the practice. Please make sure that your patients are wearing goggles for all procedures. We have a lot of procedures that add value that we're already doing, but we're not charging for or we're not charging correctly for. You've got things like Arrestin that could be used. You've got fluoride gel carriers. There's a lot of patients with xerostoma. Everybody's on meds these days. A lot of patients have gum line caries. A lot of patients have a heavy plaque index. Got a lot of biofilm going on, and it's harder for them to take care of that, especially diabetics. You might want to consider fluoride trays for home. Are we ignoring the patient's sensitivity and just telling them to use Sensodyne, or are we actually being able to apply some desensitizing resin? That's a possibility. Oral cancer screenings. I cannot stress this enough. Please, if you are not using Visalite, Velscope, Oral ID, or some other type of process to do an oral cancer screening, please, please look into that, because we cannot see visually changes on the cellular level. And we all know that oral cancer is extremely high risk, and patients have a high mortality rate because it's always diagnosed late stage. So treatment planning, we want to make sure that we understand when is the last time the patient was seen, and emergencies don't count. We can't see a patient consistently for emergencies and not have them on board. When was their last comprehensive exam? Is their hygiene program up to date? Sometimes it's just a matter of phasing and timing of multiple procedures. Like I said, if you hand a patient an extensive treatment plan, they're just going to look at the bottom line and they're not going to have any idea about, they're just going to have sticker shock. So an expert is going to be able to explain those and work with timing and work with their benefit plan to get that patient the best benefit. But that takes time. Can't be just done. We need to make sure that we run our day so our day does not run us. Route slip preparation is vital, and huddles. We need to be having huddles in the morning. And, you might be coming back and saying, okay, I thought this was about fraud and about risk. These things are all about fraud and risk, because it all comes back down to the very basics of what are we doing today for this patient? How can we best treat this particular patient one at a time, while at the same time we are protecting the clinical and the financial health of our practice. If we're not in business, it's a problem. And so it's all about risk, and we are all participants in that. It doesn't matter what position in the office that you hold. Risk mitigation is your responsibility. It only takes, just like sterilization and infection control breaches, it only takes one person to break that chain in order to have it avalanche on you. So I can't stress enough. You know, sometimes we sit there as practice managers and we just don't know what to do. We don't want upset patients. Oh my gosh, if we send this patient a statement, they're going to get so upset. Or if we, you know, dismiss this patient, it doesn't matter. We have to. There are patients that are keepers and there's patients that we need to get rid of. And the ones that we need to get rid of, we need to get rid of because they are a risk. So the keepers obviously keep their appointments. They pay at the time of service. They're compliant. They refer. And the ones that we want to dismiss are the short notice, cancel, or fails. They're payment problems. They're non-compliant. They're poor attitudes. You have no responsibility about what a patient walks in with. It is not your fault that they have meth mouth. It is not your fault that they need 4 quads of root planing. It's not your fault they need 16 crowns. It is vital that you not get into the trap of personally feeling responsible for taking care of this patient's issues. You can definitely take care of their clinical needs, and that's what we're here for. But we cannot be responsible for what they present with, and we're not responsible for their benefit plan. We are responsible to treat that patient and make sure that we work within their benefit plan to get them the very best benefit. The only way we're going to do that is to have our ducks in a row. And the only way we're going to have our ducks in the row is to make sure that we have good training and that we use our time wisely. And sometimes that involves, you know, a virtual assistant or remote training. So I'm going to ask our last question here. What is your official policy on dismissing difficult or non-compliant patients? Is there a written policy? Who gets to decide? I also want to thank Patty DeGangi because she's been just awesome at working with coding consortiums and networking and getting some new codes put in the CDT manual and being able to help us treat our patients better. She's actually dealing with benefit carriers and codes. And please look into her dental codologist membership group. We are changing the future of coding and healthcare. She has some awesome product in terms of her books are just really fabulous. And we really are trying to change the thought process there. So please take a look at her YouTube videos. And I want to make sure that I have enough time for questions. And so if you would like a sample of triage sheet, narratives, anything that you think that I might have available to you, I have all kinds of stuff. Please don't hesitate to send me an email. Put DPE webinar in the subject line and state your request in the body. Now, I do see that we have quite a few people that are responding, and I thank you for that. But please, if you want CE units, you have to be able to just give us a little information in that chat. So what I'm seeing here in comments, basically same thing is on EOBs, composites are often downgraded to amalgams. Yes, I see that very often as well. And I also see patients really upset because they weren't quoted the upgrade. And that's a problem if we don't have our accurate breakdown in our accurate coverage table. Another one I see is, yeah, the 4910s, the perio maintenances. They get downgraded to prophies from time to time as well. And usually what I find with that is Perio maintenances are typically for patients that are in maintenance after treatment of an active disease, after active periotherapy. So there may be times where we have to possibly, if they clinically qualify, we might need to reestablish those patients as perio patients. Maybe they've got an issue where a pocket or two is just not resolving. It's legitimate to go ahead and root plane those again. We want to be mindful of the patient's frequencies for root planing so we don't have a large balance on them that they weren't expecting. But if we reestablish them, it keeps that perio condition fresh in the patient's mind, as well as it kind of renews and resets their perio benefit with their benefit plan. So sometimes that's an option. Perio is really the biggest thing. Oral cancer and perio, lack of diagnosing and lack of treatment right now are the biggest lawsuits out there. And the reason for that is because offices are just not willing, in general, to stick to their guns and say this is what needs to be done. You're not going to go into, for a cardiac bypass, let's say, and you need a 3-way, 4-way bypass, and your insurance only covers one. You're going to tell your doc, okay, well, I'm only going to do the one bypass today because that's all my insurance covers. That's all I want. That's not how it works. We need to make sure that we express to our patients what their clinical needs are, why it is so important. Make sure that you incorporate the oral systemic link, mouth-body connection component in that. I'm very passionate about that. I teach that as well. And that is just such a huge thing. Patients have diabetes. Patients have cardiac disease. Patients are on tons of medications. Patients have rheumatoid arthritis. Patients have cancer. Let's please think through these processes as we're treatment planning and as we're explaining benefits to our patients. Our patients need to understand the why. All of that takes the risk back off of us. It's risk mitigation and it's proper treatment planning and proper services for the patient. After all, our patient's health is the only reason that we are in business, right? We are there as a patient service-driven organization. We want to improve the health of our patients, the quality of life for our patients. Let's see. So I think if anybody has any questions, I think Tina's going to be taking us over here.
Yes, thank you so much, Theresa, for all of this wonderful information that you've given us. I think in this day and age that was very timely. There's a lot of things that we need to know about all of these things that you've just described, and I really appreciate your time in giving us all of this information. So we're going to open it up to question and answer. If you would go ahead and type in your questions in the Q&A feature, we can go ahead and answer those for you. Now, a quick note, I know some of you are on via telephone, and so your names aren't showing up here on our site. So if you would please email me your name and license number if you would like the CE for this, and we can get that out to you as soon as we can. My email address is tina@dentalpracticeenhancement.com. And again, for those of you that have called in, we can't see your names, so if you'd like your CE, send me an email. Now, let's see if there are any questions. Does anybody have any questions for Theresa? Oh, and I just got a message from Theresa that said, for those of you that are on this call, she is offering 20% off on any of her services. Gee, I would jump on that. 20% off on any of her services for those of you that are on this call. So either reach out to Theresa or myself, and we'll get that taken care of for you, see what you need. Again, are there any questions? Don't see any. So I guess we'll go ahead and wrap this up. Again, attendees, thank you so much for all of your participation, your time during your day. We really appreciate that. And Theresa, did you have any final comments before we go?
Well, I just want to thank you again, Tina, and your wonderful team at Dental Practice Enhancement for hosting me this morning. And I know I covered a lot of information in a very short period of time. This is typically a 4 to 6 hour lecture. So I do apologize for kind of zipping through this, but I hope that everybody got a little tidbit that they can take back and maybe start if nothing else, just kind of start the thinking process and taking a look at your processes when you go home, back to your home office. And please, I can't stress enough about mitigating your risk. And if you have further questions or comments about that, please don't hesitate to let me know. I'm all about protecting the practice. We have to protect the practices at the same time as giving good service to our patients.
Okay, terrific. Well, if that's it, we'll go ahead and close out this webinar. Again, thank you so much, and we'll see you all soon. Bye-bye.
Bye-bye.